Welcome po, women's. This event is actually sponsored by Women's Ministry and Engage Team. So, we are so happy to see you today. Sige, for those na hindi po kilala ang ating speaker for today, I will introduce her briefly. So, the name is actually written here already. She is a radiologist with a special focus on breast imaging. She completed her radiology residency at St. Luke's Medical Center Global City, followed by a 1-year breast imaging fellowship at St. Luke's Quezon City, and then an ultrasound fellowship again at St. Luke's Global City. So 6.5 years of training in total. God has been good and faithful to every single one of them. Right? Tinanong. Right? So right now po, she is practicing at Medical City South Luzon and at Premier Diagnostic Clinic in Taguig. Let's so give it up for our very own Doc PJ!
I'm weakest when I'm strongest in my eyes. I'm hopeless when I rejoice in my highs. Lord, keep me low until I recognize I'm feeble till my fortress. I'm feeble till my fortress arrives.
So, a pleasant morning to everyone. I just thank God for this opportunity to be here with you today to share what I know and hopefully to make a difference in how you think about your health as women. So today, I would like to cover 5 things with you: what breast cancer is, the risk factors for developing it, the current screening guidelines, the different tests we use to check the breast, and the warning signs every woman should know. By the end of this talk, I hope you leave not just informed, but ready to act. So let me begin with one truth about breast cancer that I believe every woman should know. Breast cancer is a progressive disease. Once abnormal cells in the breast begin to grow, they do not stop on their own. They will keep growing silently without pain, without any warning, until a lump is felt or a symptom brings you to the clinic, or in the worst case, until the disease has already progressed. But screening changes that story entirely. It steps in before the lump, before the symptom. It finds cancer while it is still small, still contained, and still curable. And that's exactly why we are here today. So now, how serious is this problem in the Philippines? According to the Department of Health, Philippine Cancer Society, Philippine Medical Oncology Society, and other major health organizations, the numbers are sobering. 1 in every Filipinas will develop breast cancer in her lifetime. Let that sink in for a moment. 1 in 13. So breast cancer is the #1 cancer in Filipino women, more common than any other. And the Philippines is among the countries with the highest incidence of breast cancer in all of Asia, meaning we have among the highest number of new cases diagnosed every year. These are not just statistics, these are our mothers, our sisters, or friends, our colleagues. So breast cancer is not something we can ignore. It is something that we cannot put off until later. It is something that demands our attention right now. So let us talk about risk factors. Breast cancer is not the same for everyone. Some women carry a higher risk than others, and understanding where your risk comes from is the first step towards protecting yourself. The 2 greatest risk factors are ones we cannot change: The first is in simply being female, and the second is getting older. These two alone account for the majority of breast cancer cases worldwide. Family history also plays a significant role. It will, if you have a first-degree relative, a mother, a sister, or a daughter who has been diagnosed with breast cancer, your own risk doubles. If you have two first-degree relatives with the disease, your risk increases threefold. So this is why knowing your family history matters so much. And finally, a woman who has already had cancer in one breast carries a higher risk of developing a new independent cancer in the other breast. This is not a recurrence, it is a new disease. And it is why lifelong screening remains important after treatment. So the other group of risk factors are starting menstrual period before 12, reaching menopause after age 55, having first pregnancy late in life or not at all, being overweight or obese, and using hormone replacement therapy or oral contraceptives. What do all of these have in common? They all involve prolonged exposure to estrogen. So estrogen is known to promote the growth of breast cells, both normal ones and abnormal ones. The longer and more intensely the breast tissue is exposed to estrogen over a lifetime, the greater the opportunity for abnormal growth to take hold. Now, here is a critical point that I want everyone to hear clearly. According to the World Health Organization, approximately 50% or 20 to 30 in some journals of breast cancer cases occur in women with no identifiable risk factor other than being female and being over 40 years old. So I have patients who ask, Doc, how come I have breast cancer? No one in my family has ever had it. So, and the honest answer is this: the majority of breast cancers are not inherited. They are the result of changes that accumulate in our cells over the course of a lifetime. This is precisely why age is such a powerful risk factor in cancer. The longer we live, the more time there is for some or small errors to build up. These cellular changes can come from exposure to carcinogens in our environment, from prolonged exposure to hormones circulating in the body, or simply from random errors that happen naturally during cell division. They are not passed down from parent to child. They develop within us over time quietly, which brings back to the same conclusion we reached at the very beginning of this talk. The most powerful thing we can do in the face of these risks, inherited or not, known or unknown, is to screen regularly. Screening does not eliminate the risk, but it gives us the earliest possible chance to find what those risks may have quietly produced. That is how we stay ahead of this disease. So what exactly is breast cancer screening? It refers to a medical test performed on women who appear completely healthy. Women who have no symptoms, no complaints, no reason to suspect anything is wrong. The goal is straightforward: to find cancer at the earliest and most treatable stage before it has a chance to grow, spread, or make itself known. And early detection makes an enormous difference. Finding breast cancer early means less extensive surgery, it means a wider range of treatment options, and most importantly, it means significantly better chances of long-term survival. The earlier we find it, the more we can do something about it. Now, when should screening begin and how often? Different organizations have looked at this question carefully, and their recommendations are largely aligned. The National Comprehensive Cancer Network, it is a respected nonprofit alliance of leading cancer centers. Their most current guideline recommends annual screening mammography beginning at age 40 for women at average risk. Average risk means no personal history of breast cancer and no strong family history of the disease. The American College of Radiology shares this recommendation. What about women at higher risk? For women whose lifetime risk of developing breast cancer is 20% or more based on formal risk assessment models, the NCCN recommends more intensive screening. This means annual screening starting at age 30 and or breast MRI starting as early as age 25. So these women are not being screened. They are being screened appropriately for their level of risk. And what about women with dense breasts? This is particularly relevant for us because dense breasts are very common among Filipino women. Dense breast tissue is not a disease, but it does create two important challenges. First, it increases the risk of developing breast cancer. And second, and perhaps more immediately practical, dense tissue can hide nodules on a mammogram, making cancers harder to see. For this reason, women with dense breasts benefit from supplemental screening beyond the standard mammogram. Ideally, this means adding a breast MRI. However, because MRI is expensive and not always accessible, the practical standard here in the Philippines is a mammogram combined with a breast ultrasound, which together gives us a more complete picture than mammography alone. And here in the Philippines, the Department of Health also recommends a mammogram every year starting at age 40, fully in line with international standards in developed countries. So why age 40 and not later? A landmark study published in the New England Journal of Medicine in July 2017 gave us an important answer. It found that younger women are actually more likely to develop aggressive forms of breast cancer than older women. And because aggressive cancers grow faster, even a single year's delay in detection can meaningfully increase the risk of dying from the disease. This is why annual screening from age 40 is not excessive, it is actually necessary. Now let us talk about the tools we use in breast cancer screening. There are 3 imaging tests used to examine the breast: the mammogram, ultrasound, and the MRI. So let me walk you through each one. The first and most important tool is the mammogram. Mammography remains the gold standard of breast cancer screening. Decades of research have confirmed one thing consistently: mammography saves lives by finding cancers early before they can be felt. A mammogram is simply a special X-ray of the breast. It uses a much lower dose of radiation than a regular chest or bone X-ray, so it is safe for routine annual use. One important reminder before your appointment: do not apply deodorant, talcum powder, or lotion to your underarms or breast on the day of the exam. These products can appear on the image and can be mistaken for abnormalities. So here is what to expect during the procedure. Your breast will be placed in a flat platform and gently compressed with a clear plastic paddle. Pero to be honest, masakit siya. Pero few seconds lang naman. These 2 views of each breast are taken, one from the top and one from the side. The whole exam takes about 20 to 30 minutes. I know the compression makes some women nervous, but it is necessary. Compressing the breast spreads the tissue apart so we can see it clearly, and it allows us to use the lowest possible dose of radiation. It is brief and it is worth it. So what can a mammogram find? 3 things: masses, architectural distortion, which is a subtle warping of the breast tissue that signals something may be growing underneath, and most importantly, calcifications. So tiny calcium deposits in the breast can be the very first sign that something abnormal is developing, often years before a lump can be felt. The mammogram is the only imaging tool that reliably detects these calcifications. That alone makes it irreplaceable. So there are two types of mammogram. The first is the standard 2D digital mammography, which takes flat images of the breast from two angles. The second is the 3D mammography called digital breast tomosynthesis. With this technology, the machine moves in an arc over the breast, and a computer assembles the images into thin slices, giving us a 3D map of the breast tissue. Think of the difference between looking at a stack of papers from the side versus being able to flip through each page individually. The 3D version lets us look through the layers of the breast tissue one at a time, separating the overlapping structures that might hide a cancer on flat image. So here, the difference this makes can be dramatic. The nodule that is barely visible on the 2D image, which is on the image on the right, can be clearly seen, along with its suspicious features on the 3D image. That is the power of tomosynthesis. So the second tool is breast ultrasound. Ultrasound uses high-frequency sound waves, not radiation, to create images of the inside of the breast. This makes it completely safe for pregnant women. The primary purpose of breast ultrasound is to characterize a lump. Specifically, it tells us the one thing a mammogram cannot, whether a lump is filled with fluid or is a solid mass. A fluid-filled cyst is almost always benign and can be usually left alone. A solid mass requires closer evaluation. That single piece of information spares many women from unnecessary worry and unnecessary procedures. So there is also a more advanced form of ultrasound called 3D automated whole breast ultrasound, or ABUS. Instead of a radiologist or technologist manually scanning the breast by hand, a wide automated sensor is placed on the breast and it glides across it systematically, capturing a larger volume of high-resolution images in one pass. The result is something that conventional ultrasound cannot provide: 3 complete views of the breast, top to bottom, side to side, in a unique bird's eye view called the coronal plane that reveals the breast's internal structure in a way no other technology can. It is like virtually scanning the entire breast at once. And because the scan is standardized and complete, it significantly reduces the need to call the patient back for a repeat examination if there is an abnormality seen. So the third tool is breast MRI. Breast MRI creates highly detailed images of breast tissue using a powerful magnet, radio waves, and a computer. No radiation is involved. It is, however, the most intensive of the 3 tests. The MRI requires an injection of contrast dye to highlight abnormal tissue. For this reason, please inform your doctor or technologist if you are pregnant, breastfeeding, or have a history of allergic reaction to contrast material, or if you have claustrophobia or have any metal implants or medical devices in your body. And also mention any medication patch you may be wearing, such as a birth control or nicotine patch. When is a breast MRI used? MRI is not a routine screening test for everyone. It is reserved for specific situations where more information is needed. It is used to screen women who are at high risk for breast cancer, or women with a very dense breast where mammography alone may not be sufficient. It is also used in newly diagnosed patients with breast cancer to measure exactly how the cancer has spread and whether the other breast is affected, information that is critical for planning treatment. It's also used to monitor how well a cancer is responding to treatment, and it's also used to evaluate breast implants for possible ruptures. In short, MRI sees what other modalities sometimes cannot. It is our most powerful breast imaging tool. And for the women who need it, it can be the difference between finding a cancer and missing it entirely. Now we come to something every woman in this room can act on immediately, the warning signs of breast disease. There are 3 things to watch for: what you see, what you feel, and what you notice over time. What to look for in the mirror. So stand in front of a mirror with good lighting and look at both breasts. You are checking for any changes in size, shape, or appearance. Look for skin changes, dimpling or puckering, or skin that has taken on a texture of an orange peel. Check the nipple for any rash, scaling, or soreness. And look for any pulling inward of the nipple or any part of the breast that was not there before. Next is what to feel. Using the pads of your fingers, examine the entire breast. You can move in small circles, in wedge-shaped sections outward around the nipple, or in straight vertical lines up and down. Personally, I find this easiest to do when you are in the shower, kasi you're naked and there's soap, so it's easier to examine your breast. What you are looking for is any new lump or any area of thickened tissue that feels different from the surrounding tissues around. The goal is to know your own breasts well enough to notice when something has changed. So what to watch out over time? Pay attention to nipple discharge that appears suddenly, or any new pain in one specific spot that does not go away. These are not always signs of cancer, but they are worth investigating. So what do you do if you find something? First, see a specialist. Do not wait, do not observe it for months. A clinician will examine you and recommend the appropriate imaging, whether that is a mammogram or ultrasound or both. The only way to know that a change is not cancer is to have it properly evaluated. Second, if the imaging shows something suspicious, the next step is a biopsy. A small sample of tissue is taken and sent to the pathology lab for examination under the microscope. So third, all decisions about treatment and next steps are based on that histopathology report. The report is the definitive answer. And if it does turn out to be cancer, finding it at this stage when you noticed it yourself, when it is still early, is already a victory. The chances of survival at an early stage are at their highest. So, but the better action, the ideal action, is not to wait for a symptom at all. Get screened now. So while you feel perfectly well. This is the whole point of everything we have discussed today. So if you are 40 or over, or if you have a high risk of developing breast cancer, ask your primary care doctor to prescribe either tomosynthesis or mammogram. So early detection saves lives. I want to leave you with 3 simple words. And yes, I borrowed this from my favorite K-pop, BTS. Be aware of your breast. Test, get your mammogram, and then share this with someone. So God gave us this body. He gave us the knowledge and the technology to protect it. So using both is not just wisdom, it is stewardship. Thank you all for listening, and God bless you. So if you have any questions, the floor is open for your questions.